All right, case 1. The bowel loops look dilated. Is it pathological? Well, to figure that out, we have to compare it to the height of L5's vertebral body, and if it's greater than 1.5 times, then it indicates pathologic enlargement. So let's do the small intestine first. Remember that the lumbar vertebrae, there are 7 of them. Take the height of the vertebral body. And yeah, it's greater than 1.5 times, so it is pathologically enlarged. Now how about the colon? No, it's not pathologically enlarged. All right, next we can notice, if we zoom in, some areas of increased opacity, also in this DV view all along here. Those, what are they? They are gravel signs, and they indicate chronic partial obstruction because when you eat stuff, you're eating variably sized particles, and with the partial obstruction, you can imagine that the less dense particles as well as fluid would easily pass through, whereas the heavier non-digestible debris would settle in front of the partial obstruction and mineralize into the gravel sign. And because it seems like this is a diffuse dilation of the small intestine, it's all throughout the duodenum, jejunum, and ileum, we can estimate that the obstruction is located most likely in the distal region of the small intestine, such as the ileum. Now, in VET415 GI block, we learned that this specific combo of dilated bowel loops and gravel sign is very indicative of adenocarcinoma, so that's what we should be suspecting. And anytime we suspect neoplasia after taking RADS, we take an ultrasound of the lymph nodes. But first, let's look at the ultrasound of the ileum. Recall in GI block that we learned that the intestine is 5 layers of alternating echogenicity called mural architecture. But if we look at this loop of ileum in the patient, it looks very thickened and has lost a lot of its layering. Now let's look at the ultrasound of the lymph node. Recall that for a normal lymph node, it's going to look like a mini spleen. It has sandpaper echogenicity and it is spindle shaped. However, when we look at this patient's lymph nodes, it's very rounded, it's enlarged, and it is darker, which we refer to as hypoechoic. So this tells us that these lymph nodes are neoplastic, versus if they had just been reactive, they would have retained their normal echotexture and spindle shape. So next we did an FNA of the lymph node and ileum, and indeed found out that it is adenocarcinoma causing the chronic partial obstruction in the small intestine. So note that 2 very common intestinal tumors in dogs are adenocarcinoma and lymphoma. Next up is case 2. This is a huge area of increased opacity and decreased erosive detail. It's really hard to make out the outline of any organs here in the mid-abdomen, and it's pushing the bowels away from the mid-abdomen outwards, which is a mass effect. So anytime there is a large mid-abdominal mass, what should be high on your list of differentials? It should be either a splenic mass or torsion. And we know that this is not just effusion causing this increase in opacity, because if it was just fluid, it wouldn't be displacing the bowels away from the center. Now remember, in GI block, we learned that the spleen is located in the lateral view near the liver and the stomach. And on the DV view, it's located near the left kidney. But here, in this patient, it's really hard to identify the spleen. Also in the DV view, we can't really see it well. So if this is neoplasia, what tumor often affects the spleen? hemangiosarcoma. So the next step to decide whether it's neoplasia or torsion is to perform an ultrasound. And before we look at our patient's spleen, let's look at what a normal spleen looks like. So remember that a normal spleen has sandpaper echotexture and a hyperechoic parenchyma. An abnormal spleen, if it was splenic torsion, would have a hypoechoic parenchyma with these linear hyperechoic bands representing fibrous tissue, so it looks like Van Gogh's Starry, Starry Night because the spleen is congested and dying. And the surrounding omentum and mesentery would be hyperechoic because it's reacting to the dead spleen, so it is highly inflamed. And if we look at our patient's ultrasound of the spleen, it looks a lot like the example of splenic torsion from above. You can see the Starry, Starry Night, and the surrounding omentum and mesentery is inflamed. So now let's look at the color Doppler. And this shows that at the hilus of the spleen, where all the blood vessels are spread out, it is devoid of blood flow because the spleen is torsed and the venous is obstructed. Also, the splenic capsular margins are intact and uniform, so it's likely not neoplasia occurring here because it doesn't look aggressive. So we took this dog to surgery and found out that it indeed had a splenic torsion, so we performed a splenectomy. Case 3. So we see gas-filled intestinal organs in the thorax, and the abdomen appears pretty empty. Also, the normal contours of the diaphragm are not visible. So if we look at case 1, in which the diaphragm was intact, notice that we can see the crus of the diaphragm, the outline pretty well. But in this patient for case 3, it's very hard to visualize the diaphragm. So we might be having a diaphragmatic rupture, aka hernia. And diaphragmatic ruptures cause effusion, which would explain the overall poor detail in both the thorax and the abdomen. Also, this kidney here looks pretty enlarged, but we can double check. Note that the kidney length should be 2 times the length of L2's vertebral body in the cat and 3 times the length of L2 in the dog. And this is a cat, so it should be 2 times. So let's see. Start after the rib. And we still have a little bit left. So this is a cat, and one of its kidneys is definitely enlarged. So it turns out that this cat was hit by a car and had hemorrhage and trauma. So whatever is causing the diaphragmatic rupture is also causing trauma to the kidneys, which is why it's enlarged. And that would explain the pain upon palpation during the physical exam. Also, note that this gas-filled organ, which is the trachea, it has been displaced dorsally due to mass effect. Case 4. So wow, look, the small bowel, it has many short folds, and it's looking like an accordion. So a very hallmark reason for that is linear foreign body. It has anchored itself somewhere and it's causing the small intestine to plicate and make U-turns. There are also areas of increased mineral opacity all throughout the small bowel. And those are gravel signs. We actually often do get gravel signs with linear foreign bodies because they can get chronically partially obstructed. Now, what is this organ here? That's the pylorus. So let me show you what a normal pylorus should look like. It's nice and gas-filled. But in our patient, we have increased soft tissue opacity within the pylorus. So what's happening is that probably the linear foreign body has anchored itself in the pylorus, which is actually quite common, and it is sending strings down into the small bowel, and the small bowel is climbing up this string like an accordion, causing those plications. So just for review, remember that from ORAD to ABORAD, the order of the different parts of the stomach are the fundus, the body, and the pylorus. Case 5, physical exam is showing dehydration, there's azotemia, elevation in creatinine, so we might be thinking renal issues. And wow, look at this. That looks like a very big kidney. But let's double check. So remember we said the kidney length should be 2 times the length of L2's vertebral body in the cat and 3 times the length of L2 in the dog. And this is a dog. So L2, I can either start from the vertebra that doesn't have ribs, so L1, L2, or I can count backwards from L7, 6, 5, 4, 3, 2. But anyways, this is L2. And yeah, this kidney is definitely greater than 3 times, so it is enlarged. And might be inflammation, might be neoplasia, but we can double check with ultrasounds. So before we look at this patient's ultrasound, what does a normal kidney look like? So going back to renal block, we learned that normal kidneys should have a renal cortex with medium echogenicity, a medulla that is hypoechoic and mixed echotexture, and a renal pelvis / hilus that is echogenic due to fat. And it looks like a tomato. But when we look at this patient's kidneys, the parenchyma looks very mottled and the shape is very irregular. And there is this subcapsular fluid, aka hyperechoic cellular infiltrate, surrounding the kidneys. And both kidneys look aggressive, so it's bilateral. So we did an FNA on both kidneys and got back renal lymphoma. So some other things that can cause kidneys to increase in size besides neoplasia and inflammation would be hydronephrosis, liver shunts, things like PKD. And yeah, now I'll move on to case 6. So there is a soft tissue mass within the lumen of the bowel loops. This thing, which is really weird. There's a possible obstruction there. The bowel loops definitely look dilated with all these gravel signs. And remember to check if it is pathological enlargement. We can check that it is larger than 1.5 times the height of L5. Sorry, I don't know what I wrote there. And yep, it is definitely pathologically enlarged. And again, the gravel signs are also indicating chronic partial obstruction. So let's look at the ultrasound. And this is a very, very hallmark appearance, this archery target, and a snake eating a snake, indicating intussusception. Last case, case 7. We have this mottled, cloudy appearance with poor detail in the ventral abdomen. Whenever we see that, think either bacterial peritonitis or carcinomatosis. We also have hepatomegaly. Now, how can we tell that the liver is enlarged? Well, the margins are rounded and it's lost its sharp triangle corners, and also it is extending way beyond the costal arch. Now, what are these bony spurs called osteophytes? Well, that is indicating spondylosis deformans. It's associated with aging because as dogs get older, the intervertebral discs between each vertebra that normally act as cushioning will become damaged, and the joints between them are going to become less stable and have abnormal motion. As a result, these osteophytes develop in an attempt to reestablish stability of the weakened joint. So the spondylosis deformans is just incidental stuff. Since we are suspecting neoplasia, the next step, of course, would be to do an ultrasound. But anyways, yeah, it turns out this dog did have carcinomatosis, which is when epithelial cells flake off and float elsewhere and land on something, and that's how they metastasize.